Thank you all. All right, now it's time to soak in some knowledge. I think there are pens and paper under your seat because there's a pop quiz after this. So, fair warning, there's a lot to learn here. Okay, I'm the only one with pen and paper. Sit back, relax, but it's time to really soak in what these programs mean. Befitting this celebration, we are focusing today's program on the topic of maternal and infant health in communities of color. Given recent events, we are expecting to see an increase in births nationwide, and it is so important to have an infrastructure of health and social services prepared to support families in this journey. I would like to take this time to introduce our panelists who are here to discuss this very pressing issue. We have 3 joining us today. Dr. Gina Lowell, MD, pediatrician at Rush University Medical Center. Kirbi Range, Associate Director of Birth Equity at EverThrive. And LaRonda Castanet, Director of Project Hope at MSV. Please help me welcome them to the stage. Thank you so much, ladies. Now, before we get into our conversation, I want to set the stage for our guests as to the reality of maternal health for Black and brown women in the United States. The rates of maternal mortality and morbidity in the U.S. are some of the highest of any industrialized nation for women of color. We have some statistics we want to show you here on the screen, and I'll take you through them. So in 2020, out of 100,000 women, about 24 women died in childbirth in the U.S. And Illinois has an average of about 14.7 per 100,000. In Chicago, though, the rates are more than twice that of the national average, with about 48.6 maternal deaths for every 100,000 women. The zip codes in our city on the south and west side, that's 60612, have the highest mortality rates in the entire state. So, Gina, if I could start with you. Why are Black and brown women more likely to die in childbirth or postpartum?
This is such an important question, and the answer behind it is both simple and complex. But before I dive into that, I really want to acknowledge that the only reason I can speak to this is because of how the families that I care for in pediatrics and the stories that parents, mothers, fathers, grandfathers, grandmothers share with me about their joy in their children, their babies, their pain, their hopes, their fears, and also for the work of the Illinois Maternal Mortality Review Committee that examines each one of these maternal deaths in Illinois, Kirbi Range being on that review committee as well, and their careful examination of the circumstances that lead to these deaths. So what we understand about why it is that women are dying in childbirth is that during pregnancy and postpartum, one of 2 things may be happening. They come into pregnancy or postpartum period with a chronic health condition, and pregnancy is a state that actually increases physiologic stress as well as psychological stress in birthing people. And if you are coming into pregnancy with a chronic health condition, that can get worsened during the pregnancy or postpartum period. Now the question comes, why is it that Black and brown women should be entering pregnancy with a chronic health condition? Think about it, a 20-year-old with chronic hypertension. You know, how many of you, when you were 20 years old, had chronic hypertension, right? So that gets us to understanding what is the greater context around Black and brown women. And we have to start thinking about what we call the social determinants of health and the structural determinants of health. When you have opportunities to support women, right? Adequate access to housing, transportation, economic opportunity, educational opportunity, then you can prevent or mitigate health conditions that you might be entering into pregnancy with. But when those things are not there and not available, then those become risk factors. And we understand that that is part of what's driving the increased mortality rate in our communities of color.
Well, Kirbi, I want to turn back to you. I know she mentioned that you have some expertise in this as well. We were showing some of those statistics, especially about the South and West Side. So what else is happening specifically in those areas of Chicago that cause these disparities?
So, definitely. So we know that Chicago is a very racially segregated city. And so as we were saying, we're seeing these higher rates of maternal morbidity and mortality and infant mortality on the South and West sides of Chicago. What we're seeing is that the services and supports that you are finding on the South and West sides of Chicago can look a lot different than what you're seeing available in other areas of the city. One of the things that's very alarming that we're seeing right now, particularly on the south side of Chicago, is there is a maternal healthcare desert. And so roughly about 1 to 2 years ago, there used to be about 7 birthing hospitals available for pregnant and birthing people on the south side, and now we're down to about 3 hospitals. And so that is a drastic change, and that's a huge disservice to pregnant people and being able to access adequate care in close proximity of their homes. When we don't have these services available, these healthcare services or community-based services available for people, it's really a disservice, and it's really continuing to impact their overall health outcomes. As Gina had mentioned, social determinants play a huge indicator. And so particularly on the south and west sides of Chicago, we see things like poor access to affordable housing. There's not high quality grocery stores with healthy produce, affordable childcare, and even thinking about transportation as a whole as also. So all these things are impacting people more profoundly on the south and west sides of Chicago. So it's this ripple effect that's really affecting people. And we shouldn't have to have mothers traveling to a completely another side of town to be able to access the services that they need to be healthy. There should be options here, in their neighborhood for them to get to. So I would personally feel as if my neighborhood or my city is not really supporting me in being healthy if I don't have these options. And so it makes people, especially Black and brown people who are composed primarily on the south and west sides of Chicago, think about how is my city really caring about my health needs if I don't have hospitals or healthcare systems available to help me and my children.
Well, along those same lines, you were talking about a ripple effect. And so, Lauren, if I could turn to you, and I want to open this up to all of you. If we talk about the impact that the high rate of maternal deaths and postpartum illness for Black and brown mothers have on the community, for instance, the family, not just the immediate mother, but the family, other factors like education, what would you say would be the larger impact?
Well, when we lose parents during childbirth, it really impacts the family because the fathers are left to raise the children. The grandparents are left to raise the children. That whole support system is interrupted. And it's really difficult. As the children grow older, sometimes there's stigma about that. And it's really difficult to focus in school if you're feeling stressed. So the impacts can be long-lasting for the children as they grow up in the educational system.
I'm so glad that you brought up that idea around that dealing with stress, right? We have this term that we call toxic stress or traumatic stress. And we understand that those experiences of traumatic stress, losing birthing parent during childbirth or in the postpartum period, and other experiences of traumatic stress have a direct impact on our health outcomes, both short-term and long-term. Has a direct impact on our mental health outcomes, experiencing PTSD or depression or anxiety. And we also understand that those conditions directly impact whether or not a mom might give birth to a preterm baby, a low birth weight baby, go into early labor, or survive labor. And so understanding that stress and distress happens not only in the immediate aftermath, but also crosses generations. That's a bigger part of the ripple effect as well, that it doesn't just stay with one generation. The experiences of trauma don't just stay with one generation, but they are passed generation to generation.
And Kirbi, is there anything that you want to add to that? Okay. Well, I want to expand on your point there about the health issues and what specifically Rush is doing to address those, the outcomes in Black and brown communities. So you talk about stress. What other health issues are there, and what do you feel like the solutions could be from a Rush perspective?
There's several different ways that Rush is addressing birth equity right now. One of the ways in which we're connected to Marillac is that all of our pregnant and parenting people are screened for their own childhood trauma and experiences of childhood trauma. And those who we find are experiencing that, we try to directly link to programs like Marillac's home visiting and doula support programs. Because we understand that trauma is experienced, and yet we can also mitigate the effects of trauma. And the way that we can do that is by building stronger relationships. And that's exactly what the doulas and home visitors of Marillac St. Vincent do. They really help pregnant and parenting people build strong relationships with their babies and with each other through groups and things like that. Other things that we do too, though, however, is really addressing this lack of access to healthcare that Kirbi was talking about. And so one of the other ways that pregnant parenting people may access healthcare when they're living in a maternity care desert is to use emergency rooms as care. And so one of the pilots that we're doing right now is making sure that we're able to find every person who's been pregnant or is pregnant within the past year who's seeking care in our emergency department and link them with a community health worker who can support their social determinants of health and connect them to the appropriate OB care that they may need.
So Lorena, I want to turn back to you because the mention of the doulas and Project Hope. Tell us more about this program, and in particular the doulas, how they help make a difference in these outcomes.
Yeah, so Project Hope has been helping parents for about 40 years now. And we've had a doula program put into the program which helps mothers prepare for labor and delivery and early parenting. It's really good to have that extra layer of support. The mothers learn information about educating themselves to prepare for their labor and delivery, what to do when they get to the hospital, how they can talk with the doctor to advocate for themselves when things seem that, if things seem not to go the way they want, that they have that voice. They can speak up and be directive in their delivery. And we also help them with the early parenting. So the doulas, having that relationship, they learn to trust and they learn to be ready. When they actually go into the hospital for labor and delivery, the doulas are present with them for support. So they're there not just for the mothers, but the fathers, the grandparents, anyone who's at the hospital for the mother, they're able to support. We were very fortunate during the pandemic. We were able to continue services via Zoom. It wasn't ideal, but the doulas really wanted to be there for the mothers, to be able to support them, to be able to say, hey, I'm a shoulder here, you can talk to me. Do you have any questions? I can help you to know how to talk to the doctors. I can let them know, what you need and how they can best serve you.
So Kirbi, I want to turn back to you, and then I want to open it up to all of you. If we talk about really changing the trajectory, this isn't an easy solution, but there are definitely pieces to this that, we can all do. So before I ask you about what everyone else in this room can do, what do you think that different people in the community, the roles as doctor, the role as mentor, support, can do to really ensure that mothers have healthy pregnancies and healthy births? And how does your work specifically address that issue?
Yeah. Again, this is a challenging question because there's so many layers in what we can do. And I think the most important thing is to remember is that it is not onus on an individual person to really be able to address all their health needs. It really takes this collaborative effort. We need our community members, our community organizations, our city and state health departments, our hospital systems, insurance, and the list goes on. And so this is really a collective effort to really be able to address maternal and child health outcomes. I think I really want to emphasize the importance of leveraging community voice into all tables. It's important if we're going to make any type of substantial change that we need to hear the lived experiences of people to really truly understand how they're being impacted, what is happening in communities, and to really inform what are the exact solutions that we need at the policy level, at the community level, at the individual level to really make those changes. And we need effective data to really understand also about the disparities and the inequities that we're seeing across races. And so that's very important. Speaking of the incorporating community voice, there has been a couple of projects that the organization I'm with, EverThrive Illinois, has been involved in really tackling the maternal health crisis. One of those projects is the Chicago Collaborative for Maternal Health. We just wrapped up a 3-year project in partnership with Alliance Chicago. And the purpose of that project was, again, to really think about how we're combating maternal health. We partnered with federally qualified health centers to really think about how they can improve their practices with working with people getting connected to primary care after they have had their child to make sure that they're monitoring any high-risk conditions that they have, such as hypertension or diabetes. And then we're also had 2 components that were focusing around community engagement and policy. So with community engagement, we did focus groups with several community members on the south and west sides of Chicago to really understand about what do community members understand about maternal health. Terms like mortality and morbidity are not common terms that community members used, and so we educated community members about this topic and to find out what was it like for them to access care and services in their community. How do they feel morbidity and mortality is affecting their areas? And we learned so much, and many of the things that you all have heard before, that people feel that there's not, they mentioned greatly that the connection that they have with their healthcare system or their providers was lacking. And many people feel that they cannot trust their providers, that they're not being heard, and that they're not being engaged in their services. And it's really disheartening, especially when we're hearing that primarily Black and brown people don't feel like they can trust the care that they're receiving. So we've been using this information to think about what are the things that people need to really advocate for themselves and for their health. We put together a campaign called the Gathering Campaign, and it's really a robust toolkit website to really support people in the community with what they need to know about advocating for themselves, especially in the postpartum period, emphasizing the importance that all people should be taking care of themselves for at least and monitoring their symptoms for at least 12 years after having a child, and not just those 6 weeks. We also have something, for instance, like a glossary of terms to really bridge those gaps in the language between the medical providers and the community. So again, for our medical providers, when they're sharing different terminology with families about postpartum, many people may not be able to understand what that means, or they may associate it with postpartum depression. So we need to make sure that we're using more common terms, such as, after you've given birth, how are you feeling? And instead of, using the terms mortality and morbidity, we can say, for mortality, simply just using the terms that this mother has died, So there's various different projects that the city is really working on. Another one is Family Connect Chicago, where registered nurses are coming into the homes of birthing parents and really making sure that they have that connection to a full health screening for themselves and for their child, and connecting them to resources in the community. And so we're really making sure that we're engaging community members and organizations in this work so that they can be a part of the solution and understanding what are the needs of people, so we can integrate those services into the community.
Oh. Well, a couple of things I want to touch on, and I saw you, Gina, nodding there, but boy, that really puts it in perspective to say it's not just the weeks after, but the 12 years.
12 months.
12 months,
yes.
12 months afterwards to really be aware of your health. But if we talk about from a medical perspective, the trust, a lot of times, women, when they're going in, they don't feel like they're heard, or that their pain is actually acknowledged, those types of issues. So when Kirbi was mentioning that and how big that is, from your perspective, what are you seeing and how are you all working to sort of bridge that gap?
Absolutely. I think that is one of the greatest barriers to effective care, right? Effective care of a pregnant or postpartum person is overcoming that or being able to address the fact that there are clear issues in availability, accessibility, and trust of services. And when that trust is breached, the feeling as though a person may come back to your organization, the chances of that happening just go down and down if trust has been breached. And so we have to be able to understand that we all come to the table with implicit bias and sometimes explicit bias too. And so an organization such as Rush that undertakes implicit bias training for all of its providers, as well as not just sort of that checklist approach towards have you done the training, but actually following it up and following through with those practices and consultation that can really help providers understand what they're coming to the table with when they're caring for people in their offices. We're really proud to also be part of the Family Connect Chicago pilot as well. And one of the things I wanted to add is that when you think about what are the things that we can do to help support pregnant and parenting people, so many of the times we have kind of services and programs that are more targeted to what folks might think of as the at-risk communities or at-risk people. What the beauty of Family Connects is really that it's a universal program. Everybody has needs, and we have to understand what the range of those needs are. And then to meet our health equity goals, if you have a family that has a high range of needs, you meet that high range of needs. If you have a family that has a low range of needs, you meet that low range of needs. And this is the definition of equity and how we can achieve it. I think the other big thing that we need to really, and that you were speaking to, Kirby, too, these data systems, right? We really need to figure out and think about, in a radically different way, how can we open up these lines of communication? There's so many touch points around a family, and all of those points contribute to that family's health. How is it that we can actually get interconnection amongst those different touch points and open up lines of communication rather than always feeling like you have to operate within your own section and you can't necessarily cross a bridge, reach out, and talk to that other person or service or program that's also impacting the family that you're caring for.
So last question to all of the panelists. Please feel free to jump in. Loranda, I'll give you the floor first. So if we're talking about looking around this room, we've got some pretty impressive people in here. So what can they do? What role can they play in changing the trajectory that we're on when we talk about these issues, maternal and infant care?
Yes, being educated about the situation is very important. So just having events like this to gain awareness of what's going on, to be able to support, to be able to come in to volunteer with our programs are usually very helpful. And to also be able to provide any support or services that people have, to be able to contact the agency and let them know, and so that we could reach out and receive the things that they have to offer.
Gina?
I think that people are so ready to help support pregnant and parenting people during this time. And so if you feel like, well, I want to do something, but I'm not sure that someone would work with me, reach out. I think people are so ready to help and to connect and to work together towards a common goal. I also think that the period during pregnancy and parenting is one when parents experience a lot of judgment. A lot of judgment from perhaps healthcare providers, a lot of judgment from sometimes family members, sometimes community members, sometimes society. And if we can, instead of judgment, be curious, that can really help us overcome some of that bias that we come to the table to.
And Kirby, we end with you.
I definitely echo what Loranda and Gina has shared, and I think we just need to be okay with being uncomfortable with this conversation and this topic and recognize that there is a maternal health and a crisis going on right now. We do see these disparities. And so as Loranda was saying, we need to educate ourselves on this topic and think about in each of our capacities, I know everyone's coming in different spaces, what can you do in this space to really address maternal and child health outcomes? Because it's only getting worse and we need to do something to really improve this or our mothers and babies are going to keep dying. So we need to accept that, that there is unfortunately inequities, especially for Black and brown communities and for families. And so again, be sure to find ways that you can be a part of the solution in having these conversations. Again, include community voice into your projects, into your research projects, into your discussions to really understand what people need. Invest in communities, find out what needs to happen. Mental health is a serious issue right now for people, and we need more mental health providers and services to support people. We need more adequate housing. We need to have more, healthier options and services for people. So continue just to think about what you can do in your capacity, in your line and field of work, and think about also how we collectively, again, come together to really tackle this issue.
And I just, along the lines of people searching for solutions, I wanted to mention the MAMA Act. If it's something that you all are familiar with, I just wanted to give a little bit of information to you all as well, because I was learning about this from MSV, and of course it's been a work in progress for several years. So Senator Dick Durbin introduced this legislation to lower America's rising maternal and infant mortality rate, and specifically looking at racial disparities, trying to reduce those in health outcomes. And like I said, it's been a work in progress. So it's been over several years, 2019, and now then in 2021, Senator Tammy Duckworth got involved as well. And they're really trying to look at before, during, and after pregnancy, as you all mentioned. So I just wanted to throw that out there to let you all know that this is legislation that's at least on the radar of MSV and thinking about ways that we can, further support mothers and infants along the way. So with that, I want to say thank you to Gina, LaRonda, and Kirby. If you could please join me in giving them a round of applause.